what is new in CAIRS? What are we looking at? What is customized CAIRS? Can you tell us about that?
We are doing in CAIRS now is custom shaping of CAIRS. It has improved it much more. Instead of just getting a uniform flattening everywhere, you can actually customize your flattening to the areas that need flattening.
How do you come up with such innovation? When is that eureka moment?
Okay, that's a tough question to answer.
It's a pleasure having Dr. Soosan with us today. Welcome, ma'am, for our podcast.
Preethi. Thanks a lot.
So now we all know about CAIRS, how it has revolutionized the treatment for keratoconus world over, and we have so many countries and doctors following this technique, and we have the innovator with us. So I'd like to hear from you, what is new in CAIRS? What are we looking at? What is customized CAIRS? Can you tell us about that, ma'am?
Yeah, thanks, Preethi. CAIRS, I think, is very interesting for me to talk about because now it has caught on in so many countries and so many people are doing it. It's also giving advantage to so many keratoconic patients around the world. So what we are doing in CAIRS now is custom shaping of CAIRS, which means that we don't just, and this we've been doing since actually many years. We had actually talked about it first in 2017 and then since 2018 we are doing it. What we have to remember is no two keratoconic patients are exactly alike. Even if their overall morphology looks same, they always differ. You know, even the two eyes of the same patient are not exactly the same. So you cannot just keep a segment there and think it will work the same way or it will get you the same reversal to normal, near normal or to as normal as you can get, rather, that would be the right word, in every patient. So what you have to do is you have to study that patient's characteristics, the cone's characteristics, his refraction, his, overall what his eye looks like. And then you customize each of the segments that you're putting, which means you actually change the shapes of the segment, the arc length, the width, the tapers, internal diameter, the external diameter, the depth. All these things are actually changed. And custom shaping, I think, has really changed the way we get our results. It has improved it much more. Instead of just getting a uniform flattening everywhere, you can actually customize your flattening to the areas that need flattening.
So there's one question which I think the entire nation wants to know. When is Dr. Soosan coming up with her nomogram? Everyone keeps asking me about that. And they're all eagerly waiting for that, ma'am. Is there a timeline we're looking at?
It is very close. I will say that we are getting very close because now we are able to do almost fully automatic planning. There is a little bit of refining that is still happening in terms of getting into a graphical user interface and things like that. I think once that is also done, it will be ready to release out. But as you know, we've already been using it for so many years now. And the only thing is to make it much more widely accessible, which is what I am working towards.
They're all looking forward to that, ma'am. I'm sure you'll have a lot of takers because that's one thing which they struggle with and they reach out to us. And the other question before I close, I would like to ask Dr. Soosan, how do you come up with such innovations? When do you sit and think about these? How does that spark come in? When is that eureka moment?
Okay, that's a tough question to answer. If I have to think about it, I would say that they probably come under two extreme circumstances. One is when you're under pressure, which is either when you're operating, which is always, of course, but also when you're operating, and you are under pressure, you have a problem which you have to solve. And then, somehow, you just look at it and somehow, things fall into place. That is one situation. And the other is the extreme opposite, which is basically serendipity, which is when you are completely relaxed or when you're not thinking about this, but your brain is still having that problem somewhere at the back of its mind. And it's always been, working or thinking about that issue, not exactly right at the forefront, but at the back. And then when you are completely just doing something else, suddenly this thing comes, oh, okay, that might work there. And that's the other. I think these two would be the say, of course, working in Agarwal's helps because it's always been an innovative center for like decades. So that atmosphere of innovation is, of course, all important.
What do you have to say about this 5F technique, ma'am? How is it different from the regular glued IOL we do?
Okay, thanks for that question, Preethi. 5F, basically, let me start with what it stands for. It stands for flangeless, flapless, fibrin glueless, fully covered and fully tugged intrascleral haptic fixation. So that's what it stands for. And when I first started it out, I was doing it with a pocket technique. But then I, changed it further and made it as a pocketless technique. So now I call it as pocketless 5F. ISHF. So it's a long name, but because I've sort of made it into an acronym, now it's, it can fit in your mouth. Pocketless 5F IOL. So what this basically changes the way intrascleral haptic fixation is done is that as compared to the two commonly performed techniques, which are glued IOL and Yamane, this gets rid of the disadvantages of both and retains the advantages of both. So if you look at it, glued IOL, for example, you have to make scleral flaps. And this does not need the surgeon to make scleral flaps. So you don't have to be worried about, have you made too thick flaps? Have you made too large flaps? Have you made too thin flaps? Have the flaps torn out? Or, any of those issues. And then also it doesn't need fibrin glue. So that's another big problem. So example, if you're doing just one case a day, you have to open a fibrin glue for, that one patient. It does add on to the cost of surgery. And in many places, fibrin glue may not be available freely either. So now you are no longer dependent on the availability of fibrin glue. Those are when you compare them with the disadvantages of glued IOL. Now, comparing them to the advantages of glued IOL, it still has the same intrascleral haptic fixation, which gives glued IOL its great stability. In fact, it has an additional roughly around 2 millimeters extra of haptic fixation than glued IOL also. So, it's a very stable intraocular lens fixation, and also the ease of doing the centration, the tilt, all these things become just as it is in glued IOL. So, you have a very well fixed intraocular lens. Now, compared to the Yamane IOL, the Yamane has the problem of flanging, and flanging is something that I personally never used to like. The issues with flanging are, it's an irreversible modification of the haptic. That haptic is irreversibly changed, and then you cannot do anything to undo it. And also your flange may not be exactly the size that you want it to be. Sometimes you take the low temp cautery, it becomes too much or it's too less. Sometimes if it's too much the IOL may get decentered to one side, and then you try to do it on the other side and you keep going back and forth like this. Or if it's too large, it doesn't get tucked down well enough, and then it causes the flagpole syndrome, where it can, in the post-operative period, pop out and come out of the sclera or the conjunctiva and show up there, erode the overlying conjunctiva. These are all issues with the flanging. And the other thing is, if the flange is too small, by chance it can even slip back in. So it takes away this entire need of flanging the haptic. It takes away the need to have two needles inside the eye at the same time. That's another thing with Yamane. You have to leave the first needle in while you're manipulating the second needle. And again, that's a needle that's left not in your control, not held, but freely there, can sometimes cause peripheral damage and things like that, or at least that's in the back of your mind. Where is the internal side of the needle at that moment? So this is also taken away. You've already externalized the first haptic, and then only you go to the second haptic. So there's always only a single needle within the vitreous cavity. So these are advantages as compared to Yamane IOL, and I think this is where the 5F IOL scores over these two techniques, that it makes your life much easier, keeps the surgery easy, takes away the disadvantages of both, and also decreases the cost.
That's a wonderful explanation, ma'am. But I would just like to ask one question for beginners. Someone who has not done glued IOLs, you think they should learn to do the flap technique and then shift to the 5F, or you think it's easy enough for someone to transition immediately to a 5F technique?
Okay, that's a very good question. I think for those who have already been doing glued IOLs or Yamane IOLs, this becomes a very easy technique to transition to. It really leaves nothing to be actually learnt extra. For those who have not learned, I would say learning either of them would be equally, would be almost on equal footing. So even for the glued IOL, you do have the learning curve for creating the flaps and all those things, which also is there for the 5F IOL in terms of internalizing the haptic. So the learning curve would be the same, I think. But if you already have experience with doing ISHFs in any form, then this becomes really much easier.
True, ma'am. Thank you so much for being on our podcast, and we're looking forward to more such innovations from you, and thanks for being a great mentor to me as well.
Thank you, Preethi. It's been a pleasure.
Thank you
so much.